should be able to pick up some of them. Make sure that you use these risk factors to assess the patient properly and add value to the consultation. Physical activity. How should be the physical activity? Brisk walking is sufficient. If you are able to, if a patient is able to do jogging or running, that's fine, but that's not required. What is the best is the brisk walking for about 40 minutes per day, 150 minutes per week is more than sufficient. Cycling and swimming also are good exercises because these are the exercises where there is no injury to the body. So cycling, walking and swimming are the best ones. But if someone enjoys jogging, yes, he or she can do that also. Let's say the regularity, consistency in the exercise, about 150 minutes per week is good enough for most of the preventive purposes. In the diet, you must ask them to avoid sugar-sweetened beverages, refined carbohydrates, and then try to reduce red meat and processed meat. Coconut oil, butter, and other oils. Coconut oil consumption can be taken, but only thing is avoid in large quantity. It's not that coconut oil should be avoided. Avoid frying with any of the oils. Any oil, if it's fried bad, it should be coconut oil. But if you're using raw coconut oil, certain is not at all bad. Only thing is don't overuse it. Excessive also should also be stopped. Take plenty of green leafy vegetables, legumes, and low sodium diet and good amount of nuts. These are called as healthy diets, and these are kind of diet which is advised for hypertension also. This is called as DASH diet, diabetic approach for stopping hypertension. And overall, that will contain less amount of refined products, less amount of processed food. Never use fried food, because the moment you fry, it is the oil gets oxidized and it's a trans fat. Any oil, whether it's olive oil or whether it's coconut oil, any or seal oil, which are all these oils are good if you take them raw. The moment you fry them, they become transferred. So frying should be avoided. But unfortunately, that's one that gives the taste. The taste in the food may come from the frying of the foods. So taste buds have to be controlled. What you eat should be looked into from the perspective of quality, quantity, and the timing. It is not just the quantity that matters, quantity has to be controlled. Quality also is equally important, and timing also is important. Try to avoid late night binging, because the moment you take too much of food in the night and go to bed, all that food is converted into triglyceride and fat and stored. So coming to the awareness of diabetes, it has been seen that nearly half of the newly diagnosed diabetics are not aware of the fact that they have diabetes. You will be surprised, because we are taught that polyphagia, polydipsia, polyuria is a symptom of diabetes. It is true, it is a symptom of type 1 diabetes. In type 1 diabetes, these symptoms are very prominent. Within 2-3 months of onset of diabetes, there is severe insulinopenia, ketosis, and polyphagia, polydipsia, polyuria is very prominent, nobody can miss it. But in type 2 diabetes, the situation is different. It's basically insulin resistance, and higher the insulin resistance, longer the time for diagnosis, because they don't manifest symptoms. So type 2 diabetes should be proactively searched and screened. So don't miss any opportunity to look for type 2 diabetes if there are sufficient risk factors. Strong family history, past history of gestational diabetes, structural obesity, or unexplained weight gain, or sibling has diabetes. These are the conditions where you should be proactively searching for diabetes, because many of them are asymptomatic. So type 1 insulin-free diabetes, they become symptomatic very early. Type 2 insulin-resistant diabetics don't manifest these symptoms, and by the time they have polyphagia, polydipsia, polyuria, it's quite late. We should call it as advanced diabetes. Our aim should be to pick them up before they get all this high level of long duration of unattended diabetes, because organ damage would have occurred already if they are delayed. As I already mentioned to you, nearly 15 to 20% of type 2 diabetes have pulmonary neuropathy at the time of diagnosis. Plus many of them have cardiovascular complications. We often see patients coming here with the cardiovascular department with the MI, not even diabetic. You check their sugar HbA, which is 9. What does it mean? They have been having diabetes for many months. They were not symptomatic. So don't miss any opportunity to screen for diabetes, called as opportunistic screening. Wherever diabetic patient comes, suppose the spouse comes, suggest them to go for diabetes screening. So screening is a very important point in developing awareness of diabetes. And because it is a silent killer, even though there are no symptoms, even before they develop symptoms, it might have produced microvascular and macrovascular complications. So we should be very careful and look for the silent killer. Organizing screening camp, which many of the doctors are doing, is a very good idea. And we should identify the high-risk individuals, and if the sugar is borderline, ask them to check it periodically. Often HbA1c of say 6.2, and they are not followed for 2 years, then they come with HbA1c of 11, 12, no symptoms. So that initial opportunity where 6.2 was a warning sign, we should ask them to come back again after 3 months. We tell them to do proper dieting, and we don't post the second sampling and they forget it conveniently. And then next day come with the sugar report of fasting of 220. They say they had mangoes with last Monday and blame the mango for that. You just have to check the A1C, you know the true picture. It is 12. So a borderline value should not be ignored. These are high risk individuals. You should ask them to be very aggressive in their lifestyle modification. If you start medication too early, this is what happens. It is easy for patients to get hooked to the medications and they forget about the lifestyle modification. Give enough time for lifestyle modification, otherwise patients don't stick out lifestyle modification, they are happy taking medication. It has been seen in studies that if the medication starts earlier, the BMI goes up and physical activity comes down and obesity increases. So you must desist from prescribed medicine initially. Tell them that I want you to come try on your own for some more time. Otherwise, they simply are happy to take medicines and neglect lifestyle modification. And when managing diabetes, often we repeat to the sugar. Please remember that diabetes is a condition where sugar is one small component of the disease. We have looked into all 3 important components here: sugar, blood pressure and cholesterol. As I already mentioned, each visit we should focus on all the risk factors. You might have identified some more, but look into all the risk factors in every visit. Don't just look into the sugar. Don't be a sugar-centric doctor for diabetes. It has to be assessment of the entire person. Whole person has to be treated. So go beyond glucose and look into, focus your attention to these other important conditions also. Routine monitoring should focus on these points. Fasting sugar, post-mortem blood sugar, HbA1c, all of us are aware of that. Check the creatinine once a year. Many patients, after 3-4 years, if you have not checked it, suddenly you see that the creatinine is 4 or 5. So you have lost is crucial 3-4 years. So check the creatinine every year, at least every year. Lipids have to check once a year. If that is perfectly fine, once in 3 years is okay. But otherwise, even borderline value, you must repeat every year and then decide about the treatment. You must do the urine analysis. So it's something which is usually neglected. We do it only if there is urinary tract infection. Diabetes can have significant proteinuria. And the moment there is proteinuria, you must get alerted that there could be nephropathy developing. Plus, it's indication of other microvascular complications also. Plus, if there is active renal sediment, in case RBC, Dr. Salman will also will tell you, urine analysis is one important component of any patient evaluation because it gives you so much of vital information. And check the peripheral pulsation and ask for eye checkup routinely, not once they get into full-blown proliferative retinopathy where nothing can be done. And cardiac status has to be evaluated, especially those who are obese, those who have got high blood pressure or those who have got severe drunken obesity. Proactively ask for symptoms of angina. You may not reveal that, but you must ask for it. Examination of the feet is also important. A potential amputation can be avoided by timely intervention. If you check their feet every time when they come to you, look for pulsations or small ulcers which are painless. Patient may not know that. So a timely intervention from your side may prevent the leak. The targets are there. HbA1c should be around 7. Also normal level is 6.5. There is no need to come to the normal level. And especially those who are elderly or those who have got organ damages like CKD, we don't go for tight control at all, because by going for strict tight control, you are getting more complications than benefits. So those with established organ damages and elderly patients, a reasonable target of 8 is sufficient. And LDL should be around 130, but if there is cardiac disease, LDL target should be 100, and blood pressure should be very tightly controlled in diabetic. A non-diabetic, yes, 140/90 is okay, but for a diabetic patient, the target is stricter, because without such a strict blood pressure control, organ damage will continue. And when you are treating blood pressure, look into the postural hypotension also, because many diabetics may have autonomic neuropathy. Check their blood pressure on standing, otherwise they wake up in the night to fast urine, and suddenly they have hypotension, they fall down and develop fracture. This is one important point. Suddenly, for no reason, the sugar improves. Their diet has not changed, but all of a sudden you find that their sugar is coming under control. Please check their creatinine. As the creatinine goes up, sugar comes down, and often they come to the hospital with hypoglycemia. Then we realize that patient has already of CKD. So, unexplained improvement of sugar should also worry you, and look for CKD. Lipid control is important, either rosuvastatin or atorvastatin. If the triglycerides are elevated, we often tend to give phenobarbital, but it is not required unless triglycerides are more than 500, because the purpose of treatment is not prevent cardiac events. Even if you treat triglycerides by medication, the cardiac events are not changed. We give it to prevent pancreatitis. When the triglycerides are high, then pancreatitis. A reasonable control below about 300 to 400 is sufficient to prevent pancreatitis. So give phenobarbital only when the triglycerides are very high, because when you give along with statins, fibrate also, the muscle pain is more, side effects are much more. Blood pressure, the preferred medication is ACE inhibitors or ARBs if there is proteinuria. And often the blood pressure are high, so you may have to give calcium channel block, which is quite a potent one. Beta blockers are not preferred in diabetes, but if the patient has got risk for pulmonary disease, then beta blockers are given. All diabetics are not the same. You would have seen in your own practice that at least 4 or 5 groups can be there. These are emerging concepts. We have done a small study and found that you can identify at least 4 or 5 subgroups of diabetes. Then one group, they are lean and they have hardly any complications. 15 or 20 years of diabetes, their sugars are well under control easily, and they don't get much of organ damage. There is another group which are also lean, but they have peripheral neuropathy as a predominant manifestation. This is a difficult one. Obese patients, hypertension, metabolic syndrome, they have type 2 diabetes, they do develop significant cardiovascular complications, especially if they are smokers. And there is one more subset of obese patients, diabetic patients, who develop early kidney involvement. So the importance of identifying this phenotype is that you can predict and tailor-make your treatment options, the same concept of individuality. We call it in a very fancy name, we call cluster analysis, and come out with different clusters of diabetes. But whatever is the science behind that, you identify the subgroups and change your treatment strategy based on this subgroup. Once there is a macrovascular event like cerebrovascular event, cardiac event, and peripheral event, they go together. If you see microvascular, if there is retinopathy, or if there is neuropathy, look for retinopathy, look for nephropathy also. Fatty liver is another important condition. So Prof would have seen many diabetic patients coming with fatty liver. Others we thought it is just incidental finding, or we know that it is not incidental finding, it is a dangerous finding. Significant fatty liver will go, many of them go on to develop further damage to the liver, and they end up with cirrhosis, or for that matter hepatic carcinoma also later on. So fatty liver is no more a benign entity. First of all, it indicates a high risk complication, a high risk of metabolic syndrome. In addition, they are also, like alcoholic patients, they are also prone for cirrhosis and HCC, hepatocellular carcinoma. So in summary, always look into the patient as a whole. Sugar is one small component of the disease called diabetes. practically every organ is involved, so quickly go through the mental checklist to look for major organ involvement in your consultation. Every patient is different, individualized. Risk profile, organ involved and other associated diseases determine the overall medication that you are going to give. It is not sugar based. There was one more which I think I missed somewhere. Regarding the medication, I think just 2 minutes on that. Earlier it was all just sulfonylurea and metformin. Now they have got so many medications, now there's a problem of plenty now. Drug companies will push for new medications because that's where they have their profit is. But please remember that old medications work even now, and in spite of all these new medication groups, we have sulfonylurea, metformin group of medications, then we have got glitazones, gliptins, gliflozins, and alpha-glucosidase inhibitors like acarbose. All these medications are there, but still the best medication is still metformin. So, wherever there are no contraindications, start with metformin. Build up all other medications after that. The cardiovascular complications are minimal, are significantly better with metformin. Sulfonylurea, there is always a question mark. Whether their cardiovascular profiles have been questioned repeatedly. Some of them do produce more cardiovascular events. So, sulfonylureas like glympsos are either produce more cardiovascular complications or cardiovascular neutral. For those with cardiac disease, glyclazide or glympsos would be better. These are called as newer generation of sulfonylureas. Glyclazide and glympsos are expensive compared to glyclamide, but then they are safer as far as cardiovascular disease is concerned. And someone without any cardiovascular disease, elderly group, glyclamide is still cheap and works very effectively. Gliptins are quite expensive, but if the sugars are not controlled, other sulfonylureas can add them. The glitazones, rosiglitazone or pioglitazones, the fancy drugs are there, but then they went out of favor because of weight gain and cardiovascular complications. So wherever there is significant weight gain, patient has got persistent cardiac failure, please don't give glitazones. Although they lead to very good sugar control, but their cardiovascular profile is questionable. That's why we should not look into sugar control at all only. We should look into the overall benefit of the patient. There is no point in controlling the sugar and losing a patient. Our aim is not just sugar control. Our aim is to reduce the disease burden, reduce mortality, and that's where rosiglitazone or biclofenacin comes down in the list. Newer medications like gliflozins, dapagliflozin, canagliflozin are good drugs to reduce cardiovascular complications and also reduce renal events. But they lead to significant weight loss, fatigue, they can produce ketosis, and they can also produce significant and bad urinary tract infections, which could be fungal infection also. So these are the side effects which you must keep in your mind before prescribing this medication. And then, once we assess the patient properly, and then we give this medication, see to it that overall patient assessment is done in each visit, and that's the only way to go forward. Our aim is not reducing the sugar, our aim is to reduce cardiovascular complications and overall mortality. Thank you once again.